Hello, world. We are live in Chicago at the Midwest Reproductive Symposium International 2023. And today we are very excited to have a distinguished faculty panel that will be discussing an amazing hot topic in the world of fertility. I would like to introduce Dr. Pietro Bortoletto, who is a reproductive endocrinologist, Director of Reproductive Surgery, and Co-Director of Oncofertility at Boston IVF. And as you all know, he helps lead these live fertility and sterility journal clubs. And without further ado.
Thank you, Dr. Beltsos, and thanks to all of you for being here on our live audience, live from the 2023 Midwestern Reproductive Symposium meeting, and welcome to everyone joining globally to this live event. I'm Pietro Bortoletto. I'm the Interactive Associate in Chief for Fertility, Sterility, and the Media Editor for FNS Reports. I'm so delighted to be here with a group of friends and experts on the topic of in vitro maturation. The title of today's talk is IVM Ready for Prime Time? There's a great trio of articles that Fertility and Sterility published earlier this year under the Views and Review section that if you haven't read, I highly suggest you check out. But it really marched through the idea of what are the outcomes with IVM? What is IVM? Who stands to benefit from IVM? Something that I think a lot of us in the live audience and a lot of us international audience have heard about, but maybe don't have a ton of experience with. So we're hoping to really dig into that. But as many of you know, IVM's not new. It was done in rabbits in the 30s. It was done in humans in the 40s. And the great Bob Edwards actually did it in the 60s. But it really wasn't until 2021 that the ASRM removed the experimental label from it. And it's now a whole 3 years later. And we're here to talk a little bit about how does this fit into modern ART practice. I want to start by introducing our panel. On my left, on the con side of today's argument, I have Dr. Victoria Jiang, who's now a rising third-year fellow at the Massachusetts General REI Fellowship Program. I have Dr. Jared Robbins, CEO of the ASRM. And on the pro side, I have Dr. Luis Hoyos, who's a REI in private practice at IVF Florida. And then Dr. Scott Nelson, who has my old job, the chair of OBGYN at the University of Glasgow. Panelists, welcome to today's event. The format for today is going to be opening remarks. We're going to have 30 to 60 seconds each of people on both sides of the argument introducing their general thesis for why they're for or against. And then we're hoping to have a lively debate. There will be an opportunity for questions from the audience and from our live audience on the internet. But let's go ahead and get started. I'm going to give the con side the first opportunity to share a little bit about why they are against IVM. Con side, have at it.
Okay, a lot of pressure really starting off this heated debate today. Thank you to MSCI as well as FNS for allowing me to participate in this debate. I think that the major cons that we have to be aware of and why we haven't been using IVM is because it's just an imperfect technique right now. And with the efficiencies of IVF that we have currently, we've been incrementally increasing our success rates, having really kind of reproducible pregnancy rates among clinics, and having really efficient culture systems within our labs. Do we really want to introduce another area where we can introduce errors, not allow for streamlined of our processes, increase the workload among our embryologists for an imperfect and what still will be an expensive process for our patients? So many times we think about in non-mandated states like my home state of Georgia, when we're thinking about do we really want to go through several cycles of IUI before we proceed to IVF, or should we save $6,000, $10,000 so that we can ultimately achieve that pregnancy for you through our most efficient process that we have studied very intensely? And I think that ultimately we have to really decide what are we going to have our patients go through before we can ultimately, prioritize that pregnancy. The other thing that I think is really challenging with IVM is that IVM can be defined in a lot of different ways. So how are you exactly defining IVM? Is it from the germinal vesicle that you are getting from those small antral follicles and then maturing throughout the actual culture system? Is it going to be, M1s that you're trying to get to M2s like through the after retrieval? And so there's a lot of non-standardization that we have present, and we need to make sure that we do this responsibly, and I just do not believe that we are in that prime time now.
All right, pro side, we've heard a lot of cons there. Luis, tell us why you're for IVM.
So I think that first of all, like Dr. Yang was saying, we need to be talking the same language, right? So what is in vitro maturation? Plus or minus FSH, plus or minus HCG, with the idea of retrieving oocytes from smaller follicles, right? Or are we talking about rescue in vitro maturation, which is in a traditional IVF cycle, retrieving the oocytes and those that are immature, basically culturing, after a couple hours or overnight to see if they become mature, right? So both these techniques have different utilizations, and I would say that most of us are actually using some type of rescue IVM at least, right? So, and rescue IVM in and of itself, we know that it can increase pregnancy rates by around 5%, so any percentage is good. And in addition to that, there's a recent published article, well, this is going to be published probably in the next couple of months on FNS, that has shown that it can increase the number of blastocysts by around 0.5, right? Any number of blastocysts that we can use is getting our patients one step closer to getting pregnant, okay? So for me, the rescue IVM is a no-brainer, right? Now, if we're talking about the other type of IVM, it has several advantages that we can exploit. All this conference, we've been talking about increasing access to care. I mean, yesterday they were giving examples of couples driving 6 hours and then staying at an RV for around 2 weeks just for the process. How much simpler can it be if we, for certain types of patients, if we can just tell them, show up on this date, we'll do your retrieval without any type of medications or anything, and then we'll just do IVM. We'll let you know when you need to come back for the transfer, okay? So there is some potential here that we need to explode, right? Now, having said that, I think that we need to do IVM for some, but not for all.
Jared, I'm hearing that 0.5 extra blastocysts may be the goal of IVM. Your arguments.
All right, so I was involved in the early clinical IVM development back in the early 2000s to mid 2000s, and we practiced in a very different time. We didn't have antagonist trigger. We would stimulate PCOS patients, and then we would coast them for 3 days, and then we would stimulate them again. Severe hyperstimulation syndrome was something that our fellows learned how to take care of. The fellows have never seen severe hyperstimulation syndrome anymore. And so there was a clear need to improve safety of IVF, particularly in those high responder patients, and that just doesn't exist anymore. I think that there's potential of increasing a blastocyst with rescue IVM. I'm not saying, I don't want to make the con argument that there's no utilization for IVM, but I think, is it ready for prime time? I just don't think the data's there. Earlier during the MRSI conference, we heard Dr. Arredondo present a formula for value, which is value equals quality over cost. And one can make an argument that you are preventing value with IVM by reducing costs. But I think during this debate, we're going to argue that you actually don't reduce cost. You reduce value. You reduce quality without significantly reducing cost. In terms of access to care, and again, I think this is something an argument that we'll make during this debate. I don't think you're significantly improving access to care, and particularly, as was mentioned earlier, in today's era where we're struggling to staff our labs, you're actually significantly going to decrease access to care by introducing a procedure that our already overtasked labs can't handle.
It's probably worth mentioning that I've asked this panel to be randomly assigned to sides of the argument that they may not necessarily agree with. So some people are doing mental gymnastics here. But I want to give the last opening segment here to Dr. Scott Nelson to then go into a back and forth debate about some of the arguments raised in these opening remarks.
Yeah, there's no question about how much of the mental gymnastics I'm having to do here. So I guess the real question is it what's prime time? Yeah, and what does that actually mean in terms of the context of this debate? What we realized was that this was a technique that was described back in 1935. And in 2021, ASRM, 86 years later, decided that this was no longer an experimental technique. So ASRM already decided that it's not experimental and it is ready for prime time. And for us, I think what we're really going to spend the next few minutes discussing is who should we be doing it for and what are the potential advantages, because there's going to be a super select group, I think, for the reasons that Jared had just said. When this was developed, it was in the context of agonists and OHSS, the kind of iatrogenic risks and complications from IVF. The reality is that now in the era of antagonists and agonist triggers, we can do, say, IVF infinitely safer. And I think that's kind of where we think, where's the role for IVM and who can we benefit from? I think we probably should spend some time diving into that.
I think it's important to clarify, and I may be wrong about this, but I don't think the ASRM actually, I don't think it's proper to classify that the ASRM says it's not experimental. I think what the ASRM did, I think that the current practice opinion didn't say it was experimental, but I don't think the absence of saying that practice committee doesn't say IVM is no longer experimental. All it did was leave out the previous line that says it was experimental. It did in that practice committee, which wasn't among the papers that we were asked to read, but it did in that practice committee mention a number of things, including the fact that we still don't understand the potential epigenetic impacts of IVM on the embryo, and that this continues to need to be studied. So I don't think the lack of stating that it's experimental is the same as stating it's no longer experimental.
I read that committee opinion today, and it did say it's no longer experimental. And I respect ASRM a lot. So whatever my society, I don't know about you, Dr. Robbins, but whatever ASRM tells me, I will follow.
I hope you've got some sort of respect for his chief executive as well. So yeah.
Well, one of the things that both sides talked about is there's probably some patients that stand to benefit from IVM. Some stand to benefit a bit more. I hope the pro side will tell me a little bit, who do you think is the perfect IVM candidate? Everyone? Patients with PCOS, the oncofertility patient, who is the IVM, the prototypical IVM patient?
So I think it's going to be these new fields that are essentially kind of where IVM is going to be taking off. Because the OHSS, you can look at in terms of if they've got PCOS, for example, with antagonists and agonist trigger, you can get really high success rates with really safe, outcomes. And there's no question that that's achievable. And looking at, even look at the first transfer from the Lancet trial, you had kind of in those high responders, you've got, live birth from that first transfer at 50-odd%. So whenever we look and we can come on to the systematic review, we're substantially less than that, for sure. So I think that population can be served in other ways. There is a group of women who the treatment burden to them was so high that they experienced OHSS in the past, and they will no longer consider giving gonadotropins to themselves. They're in a fundamental fear, and perhaps there's a role for those people, because we will not be able to convince them, even with psychiatric colleagues and input and so on, because they'll be so concerned about that. So I think it's then thinking about fertility preservation and the population where we've got ovaries or parts of ovaries stored. I think that's the big population for going forward, where there's a really limited amount of primordial follicles within it. You think menopausal women have probably still got about 1,000 follicles left within them. And can we harness them, or can we take young girls where they've had it from pubertal, oophorectomy tissues, and thinking again about their long-term fertility preservation, can we do something with them? I think that's the biggest populations where IVM will absolutely have a role to play going forward.
I do a bit of oncofertility in my practice. Those patients have one shot sometimes at cryopreserving tissues for the future. Is IVM the best option that they have when they're thinking about their one shot?
What I would have to say is I think that IVM can also create a lot of false hope in these patients. And so there are clinics that are offering freeze all stages of eggs with the hope that we'd be able to have technology in the future to be able to mature these eggs and give them additional eggs, right? And so I think optimizing, maximizing the number of cryopreserved eggs in these kinds of situations is always the goal. But if you're stripping the cumulus complex from these GVs and these M1s, how can we even guarantee that there's going to be any chance that these eggs will be able to be able to be, matured in the future. And I think the other concept is that when you're thinking about storage fees and the ethics of being able to store and keep these eggs for these patients, when they come back and they come in, thaw these eggs to be able to be fertilized, how are you going to be ethically continuing to charge them fees when you have these M1s and these GVs that are sitting there that we do not currently have that technology quite yet? I think it can create a lot of false hope for patients in a way that we do not have a good standardized form of being able to mature these eggs reliably. And if you have it in 10, 15, 20 years, who knows when it's going to come?
So I think that, again, Dr. Yang is referring to rescue in vitro maturation in a sense. And I do not see the disadvantage if the patient already has some N2s. It's not like they're being charged for that extra M1 that it was frozen. So I don't think from an economic perspective there's any damage to that. Now, I would like to go back to Dr. Bortoletto's question. In terms of oncofertility, is this something that we can actually use? I would say that in certain situations, it is. I mean, we know that for our breast cancer patients, a traditional cycle, a delay of around 2 weeks, doesn't really impact survival. But even though that's the type of cancer that we see the most, it is not the only type of cancer that we see. Lymphomas, leukemias, those women are really sick, and sometimes we do not have 2 weeks. So in vitro maturation would be perfect for them. Brain tumors, what if the patient has a great ovarian reserve and I cannot use a lupron trigger? Am I gonna make her sicker? In vitro maturation, also perfect for this type of women.
There's some other categories of people that have been suggested that may stand to benefit from IVM. Poor responding patients. Do you think that there's a role for using IVM in patients who you know up front that you're going to get a small amount of eggs, and why put them through 300 units of Gonal-F and 300 units of Menopur for 14 days to get 1 or 2 eggs?
I do not think there's a role in diminished ovarian reserve patients.
No, I think that's absolutely correct. So I think if we could just go back to oncofertility for a minute, so we realize that you can do superovulation, you can do oocyte freezing. That's a classic pathway that all of us do. But what we're talking about is, can you do additive therapies for those people? I think is really what I was suggesting, whereby can we take, do that 2 weeks, and then we realize that we can also do store some ovarian tissue, because although there's a linear association between the number of eggs in the freezer and the future chances of live birth, can we then, once that's done, perhaps they're not going to have the opportunities in the future. So it's, can we add to that? So can we add to the probability that they will have their family in the future? And I think that's where we see this be the case, because IVM, if you're thinking it's just from small preantral follicles, which we might be able to see on ultrasound, but we may not be able to see on ultrasound, that's where it's really going to have a role. I think there's the classic examples that Louise has just said, in terms of who are acutely unwell, and we don't have, even 48 hours, so we've got to go that day. And the options are, we either do a laparoscopy and try and preserve some tissue, but they might not be well enough to be able to cope with that. And so that's where, as you say, a transvaginal egg retrieval into some small follicles gives them at least some hope for the future, because you don't have that. But really what there's going to be an explosion of is actually the synergistic approaches of it. And you think of Denmark, there's a huge number of women who've been freezing their ovaries in terms of that. And are they keeping them just to prevent HRT in the future, or are they thinking about family planning? And I think there's going to be a combination of both of those going forward. And that's why I think it's synergistic.
So I think you're making our argument for us. Because the question is it ready for prime time? And I do think that when we look at data from patients, again, I think the leukemia patients is a perfect example, because you need to do induction therapy within 24 hours of diagnosis. They are very sick patients. They're typically have they're thrombocytopenic. Where I think that we want to do something very definitive in that patient population, and there's a lot more data on ovarian tissue cryopreservation than there is on IVM in this patient population, and so maybe IVM is an option for these patients, but is that prime time? I think that's the argument, that while we want to have as many tools in our tool shed for this patient population, that is a clear potential, but not a prime time potential.
What is the name of that thing that you do after you do ovarian tissue cryopreservation and you're ready to use them?
But is that prime time?
IVM, right?
No, I
Okay.
think it's actually ovarian tissue graft with reimplantation. It's actually where the babies have been born. So IVM is definitely something we will hope to be able to do without reimplanting that tissue. But prime time is actually ovarian tissue reimplantation.
Let's talk a minute about the actual nuts and bolts of doing IVM. We've been talking a little bit about who the patients are that stand to benefit. Retrieving eggs. It's hard to retrieve big eggs or big follicles. It's hard to retrieve medium-sized follicles. Pro side, how hard is it to retrieve follicles that are 6, 7, 8, 9 millimeters in size?
So I think it's infinitely easier from a stimulated ovary. And because reality is we put a needle into every follicle you can see and you drain it and you let the lab worry about whether or not that's mature. I think of this, the panel, actually we accept that if you're going to put it into an unstimulated ovary, that's infinitely harder to do. And Jared's done a lot of these in the past. So perhaps Jared will be able to comment on his experience of doing these.
We'll allow you to put on your pro hat for a second. Right? How hard is it to retrieve eggs from an unstimulated ovary?
I think it's a skill set, like anything else. I think that once you learn that we're using smaller needles, it's definitely more difficult. There's no question it's more difficult than doing it on a stimulated ovary, but it's a skill set that we can learn.
And
It's not once you develop that skill set, it's really not that difficult.
And the fact that it's not easier, that doesn't mean that we shouldn't be doing it. I mean, we're subspecialists, right? We're not general OBGYN. We do a fellowship. We're fellowship trained for a reason. We provide that extra skill set. So.
But if you have an entire group of fellows being trained in programs without these skills, at what point will you actually be able to have people comfortable in doing these procedures safely while avoiding the bowel, while avoiding blood vessels? How much risk are you increasing in these procedures when you're trying to chase after these very small antral follicles when in an unstimulated ovary? I think one of the best parts of doing thousands of retrievals and being able to do these ultrasounds is that as they get bigger, they're much easier to retrieve. They pop to the top. The distance between the vagina and the ovary is much smaller. And so that is a skill set that you can obtain, but who is going to teach that? We've seen that time and time again with abdominal retrieval, where people do not feel comfortable doing those procedures because they just do not do them frequently enough. And so in what generation of doctors are we going to be starting to do these procedures, and how do we counsel our patients on those risks? Tell us, Dr. Hoyos.
I feel that we start now. You're a third-year fellow, right? So you are the future. So I think that you should start developing those skill sets, and we, as young attendings, should also work on developing those skills so we can offer the patients. How can we counsel them? I mean, the same way that we will counsel with any other procedure. I mean, I don't think it should be that should be an excuse not to do it.
Well, I look forward to coming to your institution to do a way rotation to be able to be trained in this wonderful procedure then.
I will welcome you with open arms.
Percy, tell me for a second not only how you counsel the patient about the actual technical aspect of the procedure, how do you counsel the patient towards IVM? You have the PCOS patient in front of you. They have kind of the menu of options, 3 to 6 rounds of Clomid IUI. If that doesn't work, then we can do IVF with Lupron trigger. Do you think the IVM is a stepping stone between oral medication to injectable medication? Is it a first-line option for patients with PCOS? How does it fit into your counseling?
So I think, the reality is that we're not going to be doing that. So what I was intrigued by was just saying, well, yeah, so it's clomiphene when actually that's your kind of hierarchy in Boston, when actually the rest of the world is using letrozole because of the efficacy issues. Just suggesting that might be your first step to get you to move forward. And then when you're going after that. So the reality would be that I think that for those patients, we've said, looking at PCOS patients, an antagonist cycle with agonist trigger is very safe. You can even make it safer by obviously dialing down your gonadotrophin dose. Megaset HR is a really good trial with high responders. AMH is above 5 nanograms per mil, consistent with the new definition of PCOM is 2.3 nanograms per mil. So well within that range, and you can see that you get like 15 oocytes on average, within depending on your choice of gonadotrophin. So you can do it really safely in terms of being able to do it. So I think it is very difficult to then say, oh, let's think about doing IVM in those patients when you can have this very safe, effective procedure for someone with PCOS. I think that probably brings us on to these systematic reviews in terms of kind of really nicely kind of segueing into, because the other two papers are really kind of basic science reviews, by Rob Gilchrist, which is fantastic. If you haven't read that, I would definitely recommend that. And then the colleagues in Vietnam and Michelle DeVos, so Dr. Vong and Michelle from Belgium, really trying to do a systematic review of the trials looking at whether or not was using IVM versus that for high responders. And I think it's one of the things that when you look at these papers and you look at the kind of overall conclusion that they come up with, I don't want to flip sides out to the other because it's the purpose of a debate, but it's worthwhile looking at some of the detail because essentially they say there's no difference between these arms. Yeah? And I think you probably should look at those papers in a wee bit more detail and look at just kind of how you do those. So just to dive into the trial that really drives that systematic review is one from Vietnam, from Vuong and colleagues, published in Human Reproduction in 2020. And the odds ratio for live birth was 0.71, with a 0.50 to 1.1 being the confidence intervals of that. When you go back to look at that paper, actually it was designed as a non-inferiority trial with a 10% margin associated with that. For most trials now, you either need for European registrations, you kind of need an 8% margin. Some for FDA, it's even 5%. They're kind of making it shifter. And so, if you were trying to achieve a trial size based on that, just using a control arm, you'd need to have a population for, if it was 43.6 in the control arm, 8%, it'd be 1,350 people that you need to have that. If it was 55% in the control arm, and you have a 8% margin, you need 7 to 7.2, but at 5%, you're back up at over 1,000. Yeah. So in terms of them saying it's equivalent for PCOS, it's because it goes to 1.01. So I don't think we can actually say it's equivalent for PCOS. I think in terms of going back to your question about the counselling, I would think that we should be doing letrozole, because there's some really good evidence for that, even in the New England Journal of Medicine trial and then we kind of move on to kind of IVF, because it is super effective in terms of being able to achieve them a family.
Well, you've counseled the patient about the technical aspect of the procedure. You've counseled them on the success rate of this technique. How do you counsel your lab to actually bring this in-house and do it? We talk a little bit about how to standardize protocols, make things easier, increase throughput. What does this do to a lab if you're trying to bring in IVM into a busy program?
I think that Dr. Robbins kind of mentioned one of the biggest concerns in streamlining these kinds of procedures is that we already have a very hard-pressed lab staff, and we are having a shortage of embryologists at this stage. So adding an entire new process within that lab, it adds additional checks that you have to do, changes in media potentially. Even if you do sequential culturing of these GVs to be able to get them to that M2 stage, it adds an extra layer of complexity, because then they have to go through, entire embryo culture after fertilization. And so I think that without having really successful procedures that are very standardized and very well known, even among United States studies within our own populations of people, it can be hard pressed to really try to introduce and get the buy-in from already very overworked staff that are potentially per diem, they're flying in, you're trying to address these increasing volumes. And if you increase that in complexity, I think it also increases your likelihood of error. And so I think it could be really challenging to be able to implement really responsibly within these kinds of laboratory environments when you just don't have those pregnancy outcomes to be able to really fall back on.
Jared is the only person on the panel who's actually done some IVM himself. Can you tell us a little bit about the actual practicality of doing it? Is this the kind of thing where you're taking up a whole embryologist for a whole morning, or can you do it at the bench side just down the hall and do it in parallel?
So the process is definitely more laborious. A little bit depends on the way in which you go about doing IVM. So, currently most practitioners using IVM are stimulating for 3 days. That does make some of that will make finding the eggs a little bit easier. But the IVM, the immature egg doesn't have that expanded cumulus. that most of the embryologists are looking for, that really makes it easy to identify, because particularly if you're using a really unstimulated ovary, there's definitely you have more cellular material within there. There's often blood, and so we're filtering through a 4-micron filter, and that so there's that process. So the laboratory process of finding these immature eggs is definitely much more intense. Then you have the day one check, right? And so, whereas we then have to determine whether or not the eggs are mature or not. And so at 24 hours, we're then going to go in and the protocol that we developed when I was at Women and Infants in Rhode Island is that we did a partial stripping. So we did a 20% stripping of the eggs to find out whether or not they've extruded their polar body. So again, that's another process of going. If you got, on average, we would get about 15 eggs in the process, and so you then have to look at all of these 15 eggs, partially strip them, determine whether or not they've divided, and then not really divided, whether or not they've matured, and then those that didn't, we would then culture for another 24 hours. So that's, again, you do that again on the next day. Then again, your FERT checks and all the rest. So this is essentially 2 days of work on top of your typical work in the lab. So there's no question that it significantly increases the amount of work that you're imposing on your embryologist. So that is a big con for implementing an IVM program.
And I have to point out that one of the main arguments for IVM is the cost-effective nature of it. You avoid exposure to expensive gonadotropins. Scott and I were talking about this before the panel actually started. He said that, what's the price for 75 units of Gonalef in the UK?
Oh, you can get it for less than £7. So in terms of dollars, that's probably about $9 at present in terms of exchange rates.
And the time for 1 hour worth of an embryologist is probably significantly more than that. So we're hearing kind of the pro side being con and the con side being pro here a little bit about the cost-effective nature of IVM. I want to end up by talking a little bit about IVM as a way to democratize access to care. Is this a tool that we can be using to, like I think Louis said in the beginning, give a patient an appointment for a single day to come in, have their retrieval, and avoid a patient having to have that personal expense, the time away from work, doing 2 weeks worth of stimulation. Con side, pro side, I'll let you start. Do you think this IVM is a tool to increase access?
So there's no doubt that in reality, when you look at the access to in the US, that is driven by the high price. In reality, an American today is probably cheaper getting on a plane and flying and having 2-week holiday in Greece and having IVF in a really good high quality center with time lapse, PGTA and everything, have an embryo transfer, and fly back. And she's still going to be cheaper than having an IVF cycle in the US. Yeah? So the access to the US is being driven because of the high price points. We've just talked about the difference in gonadotropin costs between the US versus the UK, for example. When you look across Europe, so the reality is access is price point driven, and if you facilitated the price coming down, actually there'll be widening access. You can then start to think about the mandates. And I think it's kind of ridiculous that you've only got IVF mandates in like 13 of the US states. It doesn't really make sense to me as to why that would be the case. So it's thinking about that, but the reality of I don't think IVM is going to facilitate access because actually all the fundamental costs that you've got is the only cost that you're really saving on is on that gonadotropin costs. And although I appreciate that's huge in the US in terms of kind of the overall price of an IVF cycle, that's the only part, and as Jared has said, that's going to be offset by having to have a more intense laboratory process. So I don't think, Louis would probably correct me here in terms of thinking about access. I don't think IVM is a way of facilitating access in the US. It may be a way of facilitating access in other jurisdictions, but not for the US.
Should we switch seats?
Yeah. What we said before, that Jared should have been on this side and I could have been on that side, but the reality was, I think as a panel, we want to kind of give a balanced opinion. It doesn't, you can play the games for debate, for being able to say that, but in reality, I think as an audience, you benefit from actually having a more nuanced discussion across it rather than actually us being forced to kind of be on sides.
And I do think, and so that's why I'm going to speak on the pro side since you spoke on the con side for a minute. I think there is an ability to improve access because what Lewis mentioned earlier is that, again, in a very busy patient population, particularly those that may live more than 40 miles from an IVF center, which is not an insignificant number of those that live in the Midwest, it is there is a huge amount of time necessary in order to do IVF. I expect to see you at 7 a.m. in the morning every day, and you're a school teacher in Wyoming. Like, that's just not, there's an impracticality there. So yeah, so maybe they do need to take the week off and go to Greece. I don't know where you've stayed in Greece, but I can't do that for an IVF cycle, unless I stay with Angie's family. We're all invited, I think. But I think that the truth is that because of the fact that IVM is so inefficient, there are, to come back to my seat now, there are a lot of new technologies out there that are simplifying that. Home ultrasound. I think there's, where I think that in terms of that prime time, while back in 2000, when we were developing IVM technology, access to care was huge for us because, again, those PCOS patients had to come in every day, right? Nowadays, I think that they don't have to come in quite as frequently, and with home monitoring, which is right on the cusp of the technologies that are being introduced, I think that we'll be able to improve those access points without having to use an inferior technology.
So there's a classic kind of phrase, I think Kevin Doody popularized it, kind of show me your monitoring schedule and I'll show you your billing. And the reality of that is that if you go elsewhere in the world, you can say, you don't need to bring people in for all of that. You say, you can use your biomarkers like AMH, antral follicle count. You can predict their anticipated response. You give them an appropriate dose. You know that the duration of stimulation is going to be 9 days. You're doing it in an antagonist cycle with a fixed start. You don't need to have the monitoring of the lead follicles. We know that that is inferior. There's a fantastic human reproduction update summary showing that that's the case. So if you've got the right dose from the start and you've got the right, fixed start for your antagonists, and you have a predicted, it's going to be on 9 days of stimulation on average, actually, how many monitoring visits do you need? Yeah, and perhaps one. And with COVID, there was laboratories around the world or units around the world that essentially said, actually, because we don't want face-to-face interaction, we're going to do one visit. Yeah, and you can do it later on, day 8, whatever, and then they can do, here's the triggering anticipate, because we all know that follicular growth pattern. So actually, do you need all that intensive monitoring? Patients love it, I understand that, but actually does it improve the outcomes in any meaningful way? I think probably not. And so, again, just other ways of being able to improve that access, so you don't need to have these teachers from Wyoming coming in the morning. Actually, why are you doing that? Why are you making them inconvenient for them and improve their experience of the IVF journey? I think that's another way of doing it.
I'll make a small plug for our live audience. If you have a question, go ahead and raise your hand. We're coming towards the tail end of the debate here, and I want to make sure that we have an opportunity to ask some questions. While we wait for a question, I want to ask a point that I think neither group has addressed, which is safety. We've talked about the patient safety with IVM versus IVF and OHSS risk, but I really want to hear a little bit about the safety of the offspring. What's the safety data tell us about developmental potential, epigenetic changes from IVF conceived children?
So, trying to prepare for this talk, you always want to make sure that you're looking at live birth outcomes and then subsequent, offspring health. And I think that's always been our kind of gold standard as fertility doctors and being able to prioritize our future generation of ART children. And, the data is just still being decided. It's just not out there. We do not understand the epigenetic changes that are occurring from prolonged culture in these kinds of environments. We are still trying to figure out, even in vivo, oocyte maturation processes. And we're continuing to do a lot of basic science studies to be able to better understand the complex interactions between all of the proteins in the follicular fluid that could be contributing to the likelihood of just getting a mature egg from our traditional IVF procedures and retrievals. And so I think the data is just not out there to be able to give us really solid, multiple studies that give us longitudinal outcomes among these children born from these processes that you can even counsel patients reliably, whereas our IVF populations through traditional controlled ovarian hyperstimulation, we do have longer studies. We do have follow-up, like 2-year, 4-year, 10-year, outcomes looking at the children of these patients and likelihood of birth defects that can be really powerful counseling tools that can allow us to feel safe being able to offer these procedures.
And we don't have the data because we're not doing it, right? So we need to do it. I mean, I was part of the task force for the oocyte preservation guideline, and I was in charge of the part about safety, long-term outcomes. And even that, there wasn't really much out there, just a couple studies. And yet, we're doing oocyte cryo every day, a lot. So, that's not an argument.
I'll take a question from the audience.
Oh, sure. By the way, I think it's a tie between the fellow and the young REI. You guys are great. And I do have a question, and then I have a comment. But first the question, and I had to write it down, is, oh no, where is it? Sorry. Oh, okay. Here, I can't find where I wrote it down. Is a minimally stimulated ovaries egg is likely to fully mature in the lab as an unstimulated ovaries egg? And what would be the success differential if there is one?
Jared, I'll give you this one since you're the only one with some real experience.
So I think the minimal. So when we do minimal stimulation, we're still retrieving at maturity, right? And so we're just not pushing the ovary as hard. And but the majority of the eggs that are being retrieved during a minimal stim IVF cycle are still mature eggs. And so the minimum stim is going to be more likely to give you a stimulated egg than an IVM cycle.
Okay.
But we did see, again, in our trial of looking at doing IVM from the unstimulated egg, we did still get maturity in about 50% of the eggs that we retrieved.
50? Mm-hmm. That seems high. Okay, and then my comment regarding would it be a way to democratize, what did you say? Democratize access to care, the performance of IVM. I think it would be a way to democratize human exploitation, and this is why. Because you can't separate donor anonymity globally from the equation. One, there are countries that harvest babies. I have proof. I have photographic proof.
We're not talking about IVM and donors. I'm just going to pause for a second there.
I'm just saying,
it's a very
important,
different scenario.
The value of a human ovary at birth, ovaries is $1.7 billion.
We're going to separate the conversation a little bit about donor versus autologous IVM because I think they're very different scenarios with a lot of nuance that I don't think we have time for today's debate. I want to pose a question for both sides. I want to ask both sides. There are groups internationally outside of the US, Vietnam, Belgium, Australians, that are doing this at scale and have been doing this at scale now for a few years with their data being published. What are the things that are missing in North America for us to be able to bring this into prime time if we're not ready for prime time now?
So I think the most important thing that we need to use to contrast ourselves versus those others is universal coverage of IVF, right? So if I'm gonna ask someone to shell out $7,000 to $25,000, I'm gonna make sure I'm giving them the thing that's gonna be the most value for their dollar. I think it's much more reasonable to start thinking about can we think about that value scale that Dr. Arendado proposed? We can look at that value scale when we can really reduce that cost, the denominator in that equation, and that's where in the U.S. we have to continue to push for mandated coverage for IVF, for fertility care in general.
Coverage and staff. So
I'm thinking about access to care also is I'm not entirely convinced that this would make it a particularly cheaper process. You will be saving money from a gonadotropin standpoint, but it doesn't necessarily address the increases in add-ons, the increases in the lab fees that we would be charging to be able to have these IVM procedures performed. Even if you do have just 3 days of stimulation, you still have to have the ultrasound. You have the same evaluation. You're going to come in and you do the retrieval. That's a fixed anesthesia cost. You have 2 additional days potentially of culture before you start the entire process of IVF in and of itself. And so I think, thinking about bringing more patients into the clinic, I think is great, because that obviously will democratize it in a lot of ways by limiting the number of visits that you have to have. But that doesn't address the amount of REIs that we need to be able to be training every year to be able to account for that increased volume. It doesn't account for the number of embryologists that we would need to hire and train to be able to provide that additional staff. And so I feel like at this moment, if you were trying to introduce IVM as the prime time treatment plan in the United States, I think cost is going to be a huge limitation.
What about rescue IVM?
I thought we were just talking about specific types of IVM, but rescue IVM is definitely being introduced in a lot of clinics pretty reliably, and I think that if you're already going through the process, but you have to recognize that it still doesn't necessarily address the high cost of treatment that patients are battling to be able to afford it. Coming from Georgia, our patients in Atlanta are mortgaging their houses to be able to go through one cycle, and so if you're thinking about equating it to the oncofertility population, where they may only have one cycle to be able to go through, I think rescue IVM is great in that scenario if you can get one more blastocyst that could give them that chance to be there. But I think if you're thinking about IVM truly from that small antral follicle retrieval, I just don't think that we're there yet.
And I may agree with you, but I think the rescue IVM is probably ready for prime time, right? Those patients, the one that got a mortgage, whatever, a reverse mortgage, they're already going through the process, right? And we know that increasing the number of blasts is going to increase the chances of getting pregnant. So if you already have those immature eggs, and we know that we can get blasts from them, I think we should use them.
Well, we're nearing the end here of our time together. I want to give both sides an opportunity for their closing remarks. And summarize for me kind of the general takeaway point for why you are pro IVM being ready for prime time and why you're against IVF being ready for prime time. I'll let the pro side go first.
Yeah, I think that was kind of a closing remark already.
You tapped out.
So I think what we recognize is that for ProCoin, in terms of prime time, it's prime time for a very specific subpopulation. I think that's what I would suggest, is that we've heard that rescue IVM, so what we mean by that is whether if someone's gone through a conventional IVF cycle, but they have got a low number of M2s with that. So they have a high egg yield, but a low proportion of M2s. Actually, by increasing that, that's advantageous for them. So that's a rescue IVM cycle. And that makes sense, and that's probably what your labs are already doing. Or if they're not, they should be doing that, because as you've said, you've spent an inordinate amount of money to get to that through that first stage, and it's not going to be an incremental cost, it's not going to be that excessive for that. So that's rescue IVM, where there's a subgroup of population, fantastic response, but low M2 yield, right? So that's slightly different. Then there's the question about who are we going to do standard IVM in, and then you can have that into the context of biphasic. So there might be, as Jared talked about, having a small dose of gonadotrophins with that, small dose for a couple of days in terms of that. And we think there's potentially really limited subgroups of populations that benefit from that. And then I think the last group is really those who have got oncofertility, where they can do conventional, oocyte or embryo banking, and then they're going to have cryotissue preservation. And then in addition to that, can they also be thinking about IVM to thinking about the number of follicles? Because even if you do classic transplantation back into them, autotransplantation, that's a relatively small number. And can we also perhaps take other bits that can we do IVM and increase the number of oocytes from that? So in reality, it's potentially is prime time, but it's for these super select populations. It's not for the hundreds of thousands of IVF cycles that are undertaken in the US, every year. It's for very specific populations, and that's where we think there's benefit for it, and you can be doing that routinely just now.
Okay, so
Dig deep, Jared.
So I do think that there is, obviously, I think that there is, there's value for IVM in the world. The question is how much, and should IVM be a mainstream treatment strategy? I would say very much no. Are there subpopulations where, we've been talking about personalized medicine? Are there subpopulations where IVM is appropriate? Yes. But they're pretty small subpopulations, and perhaps should be focused on specialty centers that could do that would do IVM routinely. I'm not a fan of rescue IVM, by the way. Dr. Rakowski has I've had pregnancies from rescue IVM, so I know that it does work. But Dr. Rakowski actually has a paper demonstrating that we all know that blastocyst does not equal pregnancy, and that the overwhelming majority of blastocysts that are formed by rescue IVM are incompetent. And I can go over the data, this biology as to why that is, but we don't have time to do that. So I don't know that. I think rescue IVM should also be reserved for those extreme cases. I wouldn't be doing rescue IVM routinely in a laboratory. And so I think that IVM is something is a tool we should have in our tool shed, but is not something that we should be using routinely at this point in time. And I do think that idea of creating false hope is concerning to me, particularly in creating embryos that may ultimately not have significant potential to become children.
The concept of therapeutic misconception.
Right. Final word.
Take us home, Dr. Jiang.
Well, I think we've heard a lot of pros and cons on both sides, and I think it's undoubtable that IVM will have a place in the future of reproductive medicine. But I would just say that.
And scene.
But is it ready now?
Thank you.
Is it ready for prime time now? I would say it would have to be overwhelmingly answer no. I think once we have larger institutions that do more studies, I think, is it responsible for us to be charging for this now? I say no. I think that if we have the data, if we have institutions that are going to be interested in developing these protocols through research IRBs and being able to actually demonstrate reliable reproducible pregnancy rates and be able to offer it as a middle ground between IUI to IVF, it could be an option, but in select populations too. But I think right now the jury's still out, and we still need to figure out how we're going to be able to do this responsibly.
Well, I look forward to hosting this exact same event in Vietnam, Belgium, or in Australia and ask the exact same question and see if we come up with a different answer. I will ask for a round of applause from our live audience for our panelists here on both pros and the con side. I also want to make a mention of our next live event. We're doing a unique event this year. We're actually going to Acapulco, Mexico, and we're doing a live event from the annual reproductive medicine meeting from the Mexican Fertility Society. That's going to be on July 20th. The editor for Fertility and Sterility, Dr. Kurt Barnhart's going to be there chairing that panel discussion. And that's going to be in Spanish, which is also a nice change of pace for Fertility and Sterility. Si se habla español. I want to thank you, our live audience, and thank our online audience for joining. If you found something on this topic that you want to expand upon, I want to make the offer. Fertility and Sterility has this new and revamped section called Consider This, which is a online-only original content section of Fertility and Sterility where we're inviting all of you to write a little bit more about things that don't fit classically into the journal. So if you have an opinion, if you have an idea, if you have a commentary, this is a perfect place to submit it. This does not live behind a paywall, imminently shareable on social media. So if you have something to say about IVM, I encourage everyone to check that out. You can submit it on fertstart.com. Again, thank you so much for being here live with us in person and live with us at home. And that's all we have for today. Thank you so much.